Okay, hi there. This is Elliot Fishman, and hopefully I am live on Facebook. And I know if I'm not, Lily is going to tell me I'm not live or I am live. And this is something new we're going to try. And what we're trying to do is basically share with you a talk. So let's see, Lily sees the PowerPoint, so let's get started. So we're looking at different things we can do on Facebook Live. And so one of them I thought would be a case conference. Now, just to let you know that I've run a case conference at Hopkins for the faculty for about the past dozen or so years, every second or third week. And I would show interesting cases, just scroll through them and go over them. Cases where we did really good, we didn't do so good, or just interesting cases. And then when COVID came along, we couldn't meet. So about 40 some odd weeks ago, literally we've been doing this over 10 months, we decided to have a case conference where I would show cases in the PowerPoint format. And then we would, instead of me just going over them, which is really boring, we'd call on people. And to make things even more interesting, we would call on the faculty. So only the faculty answer. So we have faculty and fellows and residents and all sorts of people attend, but only the faculty would be called on. So this way no one would feel put out. And they were often very difficult cases and challenging cases, and I thought it would be terrific, and it's been terrific, and it's been good for the team spirit as well, for people to be able to answer questions, take difficult cases, not get everything right, but, hey, that's what the real life is. So what I'm going to do with you is show you a bunch of cases, to quote Yoda. I'm going to show you a bunch of cases, then I'm going to ask you for the answer. And this is just the way I'm going to show you 4 or 5 cases that I actually did at yesterday's conference. Now, the difference is someone else would be talking, and we are working on this process, trying to do it better, so you're only seeing my screen, you're not seeing me. Hello, I'm waving if you could see me. And also, it's only me answering it. Now, I think what we would like to do is have other people answer it. So I can't really see the way this is set up right now on my laptop. I can't see any of the comments. But it's a great place to ask questions and comments, and maybe at the very end, I'll come back and I'll do that. But so let's go through this. So what am I looking at here? Well, what you're looking at is a mass in the heart in this patient with chest pain. So the question, of course, was PE versus dissection. But you see a mass here that's involving both the left and right atrium, right? It's a big soft tissue mass that's involving the heart. It's not a thing like a myxoma. This looks like a malignant tumor as it's invasive. Usually a bit more anterior in the right side of the heart by right atrium, you think of angiosarcomas, but that's a possibility here. You always think about metastasis, things like tumors coming up the IVC, hepatoma, adrenal cancer, and renal cell carcinoma would come to mind. But usually it's typically then only going to be within one of the chambers, typically in the right side of the heart. And you can see here it's very bulky. Now again, when you think about cardiac tumors, the most common cardiac tumor is metastasis. I'll tell you this patient had no known primary. You don't see anything coming up from beneath the diaphragm, so it's primary. Well, what could this be? There's several things that you could think about. Here's just a 3D image, but here's a very good another image, which is this patient's mass within the abdomen. And when you see that mass, you could say, well, it could be an ulcerating adenocarcinoma. It could be a lymphoma, perhaps. But what this ends up, and with the ulceration, could be a GIST tumor, perhaps. That would be less common. So now you say there's a mass involving the heart, and there's a mass involving the small bowel. So you think about lymphoma. That's going to be the best diagnosis. Metastasis is a thought, but you'd have to have a small bowel primary metastasizing to the heart, like an adenocarcinoma. But you think about heart and small bowel lymphoma, more common in immunosuppressed patients, more common in HIV type patients, more common in AIDS patients. So really a nice case. Another case. Okay, that's case one, number 2. This patient has back pain. Now, when you look at this first set of images, what you're really looking at is what's going on around the aorta, right? You can see the soft tissue infiltration around the aorta, in a sense narrowing a little bit the aorta. Now you can say as well, maybe it's an aortic aneurysm that leaked. That's always a possibility for soft tissue around the aorta, but I don't see a leak. You could say, well, maybe it leaked in the past. You might see some irregularity. I just see compression here. But you could think about the fact that it could have bled previously. And now you're looking and you see the process that we're talking about is also extending further down, right? It's extending down along the common iliac arteries and extends down along the common iliac and the external and internal iliac arteries. So it's an infiltrating process. Now, one of the things when you see soft tissue processes like this in the retroperitoneum, you want to look at the kidneys, because when you have inflammatory processes, often the ureters get pulled medially. You can see how on the 3D it's really infiltrating the retroperitoneum around the aorta and around the common iliac artery. So very nicely seen in that regard. And then here it is again, another set of images showing that very nicely. And so what are you dealing with? Well, you could think about lymphoma, but it's sort of infiltrating and smooth. You can think about perianeurysmal fibrosis from a leaking aneurysm. I didn't see that. But the process you think about is retroperitoneal fibrosis. Soft tissue infiltration around the aorta, narrowing, compressing the aorta, just infiltrating, maybe narrowing the IVC, pulling the ureters medially, extending downward. It can narrow the lumen. It can cause all sorts of issues with lower extremity swelling. There's a lot of different causes, including certain drugs. It's a great case. Wonderful example. Okay, another patient. This patient has a mass, and you can see there's a mass in the pancreas. So what could it be? Well, we could be thinking hard. This was sent to us as an adenocarcinoma, but you start seeing calcifications. And you see it nicely on this volume rendered image. Now, one of the things when you have a pancreatic mass and you have calcifications and you exclude the fact that it's not from chronic pancreatitis, you then say what things calcify. Well, neuroendocrine tumors are the most common things I think that calcify. We've seen that. Adenocarcinomas just don't calcify. Metastasis, I mean, if you have a renal cell that bled, but that's extremely rare as well. Lesions that calcify, you think about where the calcifications are. Central calcifications, you think about serous cystadenomas. They can have the stellate calcification. Rim-like calcification, you can think about an MCN, mucinocystic neoplasm, or you can even think about IPMNs occasionally. But this is coarse and it's rim-like, but it's more than rim-like. It's more extensive. Now, if I told you this patient was 25 years old and it was female, you would say, aha, this must be a SPEN tumor. But this patient was much older than that, though it was female. Look at that rim-like calcification. I kind of have problems with calcification in the sense there aren't that many things that can do it. It's not, I said, not going to be adenocarcinoma, not going to be metastasis. It's not going to be a serous cystadenoma, which doesn't have rim calcification. MCN, it's a lot of calcification. I guess it's a thought in the right age group. This patient, again, coarse calcifications, not vascular. This was a SPEN tumor. So SPEN tumors, we've seen a bunch of them now with calcification. It can be in the periphery, it can be central. Again, SPEN, solid papillary epithelial neoplasms, are more common in younger female, in the teens and 20s. So the age usually is a great way of making the diagnosis, but not always. So it's something, again, you need to think about. Great case. Now, this patient was sent in for an FUO, and it was felt to be a pancreatic abscess. When you look carefully at the pancreas, it looks like a necrotic process in the head of the pancreas. And I've seen this a few times. Once you know what this is, you're not going to have a problem. But you say, gee, could this be pancreatic necrosis? But if you have necrosis of the pancreas, how come there's so little inflammation around? That should make you question your diagnosis. Also, if you look, this process seems to be communicating with the duodenum. So maybe you say it's a duodenal perforation with an abscess. But there's mottled density like food matter in there. Well, if you've seen this once, you will always remember. This is an appearance of a duodenal diverticulum. Duodenal diverticulum can be small or they can be large, but at times they can simulate other processes. And in this case, the duodenal diverticulum is simulating an abscess. So this patient was sent to us. The FUO was just, patient I think had pneumonia, nothing very, very serious. But this was not a pancreatic abscess. It did not need drainage. It did not need surgery. So you want to be very careful. Once you've seen it one time, duodenal diverticulums can simulate IPMNs when they're small and well-defined and cystic. They can simulate a dilated common duct. They can compress the common duct, but they can also simulate an abscess, particularly when they get large and you're looking for an abscess and you don't see anything else. So a really good informative case. Now, another case. What about this one? Here's an incidental pancreatic mass. So now I'm giving you a cystic pancreatic mass in the head of the pancreas. You might ask the patient's age, because certain things like MCNs, which usually are in the body, are more common in 45 or 50-year-olds, and things like serous are a bit older. But you got to think to yourself, well-defined and cystic, what could this be? Well, it could just be an IPMN. That wouldn't be so bad, right? It could be an IPMN. It could be an MCN, not a great location. It could be a pseudocyst, the patient had pancreatitis. There's also a little bit of rim-like enhancement here, perhaps, or vessel stretching, and you could say perhaps we're dealing with a cystic neuroendocrine tumor. They typically have rim enhancement, but 360, not just part of the lesion. And when you look at this lesion a little bit closer, it's so well defined, okay? And you really don't see that rim enhancement that you would see with a cystic neuroendocrine tumor. So now you get back to saying, what's a cystic lesion? Well-defined water density. What about serous cystadenomas? Well, then you say serous cystadenomas are typically multiple cysts. They have septations, but not every serous cystadenoma. There's an oligocystic serous cystadenoma, which is a well-defined cystic lesion with, guess what? No septations. Just a beautiful example. And when you go through the images, serous cystadenomas can obstruct the pancreatic duct. This doesn't, but they can. But they have a really classic, well-defined appearance, a very important differential diagnosis. Serous cystadenoma is more common in the tail. They're often larger. They have the septations. They often have calcification. It's just one of those tumors that can look like many things. Serous cystadenomas do not have a malignant potential, but when they start getting above 5 centimeters, they typically will be resected to prevent any problems. Now, what about this case? So this will be the last one I'll show you. The patient has back pain, and when you look as you see, in the left upper quadrant, there's a pseudoaneurysm here. Now, typically, I would say without looking hard, and surely at the first image, I would say it must be a patient who had pancreatitis who developed a pseudoaneurysm of the splenic artery. That's the classic story, and that's a great location for the splenic artery. Unfortunately, you could see that this is coming off, and then you see the splenic artery here, you say, But then you look a little bit more closely, and you can see it's a pseudoaneurysm. Pseudoaneurysms in this region are very common secondary to pancreatitis, particularly patients with repeated episodes of pancreatitis. And if you look carefully at the MIP, the splenic artery is separate from this lesion. This lesion actually comes off the left gastric artery. Kind of just a beautiful example of that. I don't think I've seen a left gastric artery pseudoaneurysm in a long time. This was eventually embolized. This also shows the importance of giving IV contrast. If this was a non-contrast study, you could have read this as a pseudocyst, maybe a hemorrhagic pseudocyst or a high-density pseudocyst. You need IV contrast to recognize the blood components of the pseudoaneurysm. Pseudoaneurysms over 2 cm can easily spontaneously rupture with high morbidity and mortality, so this typically would be resected, though these days it's typically embolized. And this was eventually embolized, and the patient did great. Left gastric artery pseudoaneurysm. So that's the end of my terrific cases. So what I'm going to try to do here, hey, this is Elliot, and I'm back now. I just learned something new. When you get out of, and Lily's sending me a note that, oh my God, you cut off. I think your internet cut off. No, Lily, I pressed the button because I thought I might be able to go back from my PowerPoint presentation directly to be able to speak to you live. But I'm not able to do that. So I'm gonna keep going, and so hopefully you guys liked it. I unfortunately am not able to see the comments from the prior thing because I can't do 2 things at one time. I can't go back into PowerPoint, which I'm at. But if I will look back and maybe answer any questions people have later. So I would like, if anyone has any comments or thoughts, if they like the process, if they like this idea about going over cases, I think we're going to work on, Lily, Sarah, and myself, we're going to work on some way of, we're trying to think how to do it, maybe to give you the questions in advance and let people answer them, and then go through some of the answers people submit, or figure out some way of people being able to pop up answers that I could see the screen, because right now I wasn't able to see the screen. So I think it's something we're going to learn, but hopefully it's something that you like. So I'll just say, I'll see you later, alligator, and let us know what you think. Okay, have a great day. Hey, John Biacchino from home. I'm sure John's only not that 15 minutes from me, so I'm sure he has a lot of snow and ice by his house as well. Okay, bye, guys.